Good afternoon, everyone. We can see that people have found time to be with us. Just to test that we are being heard, I'll ask Loveday from Western Province if you can hear us. Dr. Loveday, good afternoon. Can you ask Dr. Loveday? Okay.
On behalf of Dr. Loveday, you are loud and clear.
You're loud and clear. The host had muted us.
Thank you, Dr. Mwila. We hope you stay quiet in Western Province, but you might have cases as we move on. My name is Dr. Sivile. For those of you who don't know me, I am the head of an infectious disease unit at University Teaching Hospital, and I'm supporting the case management cluster for the integrated incident management system, the IMS, the national IMS for the response for cholera. We've decided to have some sessions for cholera case management simply because the epidemic the outbreak is getting out of hand, and we are having a higher case fatality rate than envisioned or where I would like it to be. So we hope that our session today is going to be short, maybe just an hour. We'll allow for questions. We're going to give a small overview of where we are with the epidemic, and Dr. Sinkala will delve deep into case management of cholera. Dr. Sinkala, good afternoon. You can greet the people. You've been in the center for some time now. Good afternoon.
Good afternoon, Dr. Sivile. Good afternoon, everyone on the call. Welcome to this session, and we hope to get through it nice and smoothly. And we hope that learning does take place as we continue to manage and battle cholera. Thank you.
Thank you. So we are going to go ahead and start. I'll give the preamble of where we are with the epidemic. Where's IT? You can help us with sharing the slides, IT. And the video. The video.
So we stop sharing.
No, it's fine. You can share it. It's fine. Okay. We hope you can see the slides. So we'll give you, like I've said, our session is going to be in two parts. The first part is just going to be programmatic, where we are with the epidemic. Then we are going to look at the case management. So in Sub-Saharan Africa, like Southern Africa mostly, we are again embattled by the epidemic. Now, to start with, cholera is a significant national public health problem that we know. It's an old disease with key associations of poor hygiene, and mostly is poor drinking water. And occasionally you have poor food handling processes. There are several things that I would like to say from an infectious diseases point of view for everybody to learn. The first one is Human-to-human transmissions are very rare. Almost all transmissions would occur because of exposure, like I've said, to poor handling or poor sources of water. In Zambia, the first outbreak was recorded in 1977, but this is on record. You would presume that the epidemics were there even prior to that. We had our major outbreak, of which a number of us were involved in 2017, 2018. Over 100,000 cases we've had in the country, but like one would say, this is an understatement because a number of cases remain unreported. Case fatality rate has been high at 4%. If you compare other epidemics that occurred earlier in Europe, before the disease was probably non-existent in Europe and North America, case fatality rate was below 1%, and even now in South America, case fatality rate is way below that. It's in our setting where it's hovering around 4%, 3%. Right now, as we are going to share, the case fatality rate is around 3%, 3 to 4%. This is extremely high and unacceptable. That's why we've called for this meeting, that probably we can improve in some of the things. Right now, and historically, major hotspots have been Lusaka, Kapura Province, Copper Belt, Northern Central, and Southern Province. In the last few years, we've had challenges with Northern Province up in the shores of Lake Tanganyika, where the cases have been coming from. And that's the graph that was on the other side. It's just where we are. As of today, the 3rd of January, 2024, in this current epidemic outbreak, should I call it, we've had 3,700 reported cases. These are symptomatic cases. You would want to know, but only about 5% of those are infected with Vibrio cholerae do progress to have cholera gravis, as it is called. This is where you have profuse vomiting and diarrhea. So you would want to assume that the number of cases that we've had are far much more than that, and this should be maybe just the outbreak that we are seeing in terms of individuals that have been affected or infected by the disease. Unfortunately, we've lost 128 cases. As a cluster, like I've mentioned, this case fatality rate of 3.4% is something that we need to work on and try and reduce it to probably below 1%. Of course, there have been reports that a number of these cases have been BID, brought in dead, in-facility deaths like Levy, where Dr. Sinkala is heading the cholera treatment center. You only had one mortality, right? But three now. Yeah. So these are fewer to give you a sense of where most of the patients are. And the number of those have had some comorbidities. And this is typical of our response. We are not using, like he's going to explain, we are not using microbiological diagnosis for someone to be in the center and treated. In most cases, especially when you are in an endemic place, like where we are, laboratory confirmation is not required for you to manage the case as cholera. This is per WHO and national and historical standards that we use. So it's case definitions of diarrhea, and a number of those cases might not be cholera itself, but they're supposed to be managed as such. Therefore, the call is for one to be alert as we are managing these diarrheal cases. All other causes of diarrhea might be possible. You know that diarrhea is a common presentation, but because we are in the situation that we are in, all cases are managed as cholera based on the cause definition. In the last 24 hours, unfortunately, we've had 16 deaths. This is very, very high. A number of these, when we've looked at them, they look like true cholera cases. And quite a number were also BIDs coming in late. Therefore, for the individuals on the call, take-home message is our messaging should change. We need to include early presentation to the facilities. We are noticing this resistance because we are reporting these high deaths. Some facilities or individuals in the communities are beginning to believe that if you come to the center, you will die. But the messaging should change, that we want individuals to come to the centers early. We are going to do a deep dive into the deaths, and in due course, we'll update you on what is really going on with these high mortalities. But 15 of them were in Lusaka. Currently, over 500 admissions. Not a good story. We would like this to, and that's where the cases are. Like we know that Ulungu is a challenge. Historically, and Sinazongwe, those near the lakes, they are actually endemic districts, but we are seeing all over the place in places where probably should not be the hotspots like Petauke and so on, reporting cases. And obviously, Lusaka district tends to be the forerunner. Likely that the situation will change to involve other districts. We need to be ready, even there were in the districts that are not highlighted here. As our population keeps on moving, schools will be opening, everybody will be moving all over the place. For Lusaka district, this is where we are. Most of the admissions are here, 541. And we've had 3,000 patients from Lusaka, 121 deaths are from here, and those are the discharges that we've had. And again, Matero, Kanyama, Chawama are the forerunners. You can see Matero, 1,000 patients there. Kanyama, 900. And then you are coming down to Bauleni, 300 cases, 370 cases, then Chawama and Chipata are sub-districts. And admissions, most of the admissions have been in Matero and Levy, where we are keeping these individuals. And most of the deaths, like reported, there have been BIDs in Matero and Kanyama. And this is just our epi curve cumulatively where we are. Next slide. Other cases in the other districts in Lusaka province in the last 2 weeks, this is where we've been. Unfortunately, it's this rise, you can see, of 71.2% we've experienced as a province. It means we are peaking and not on the downward trend of the epidemic. And this is just by sex and age. Children are the commonest. You can go back to the slide. And again, this is because the pathogen itself, in the people that are infected, over 80% will be asymptomatic. It doesn't mean that the children are the ones that are susceptible. It's from literature, we know that progression to symptom is more common in children than in adults. Reason being, they have less immunity, and this is less for the breastfeeding children. So if you do look at that number, if you go down to the infants, it will be lesser in that population. It will be the kids non-breastfeeding, those below 5, maybe 1 to 5. And children are more symptomatic, but you would expect that more adults are actually infected. A number of adults, most of them will be asymptomatic. A few of them will have mild symptoms, maybe just an episode of diarrhea here and there, and only very few, less than 10% will have cholera gravis, needing maybe diagnostics or hospital visits. And the above 40 are the next group. And similarly, it's just that being prone to become symptomatic. That's the reason why there's this change. The 20 to 24, we feel that this will be the bulk of those that actually do get to be affected by the disease. That's why it's much higher. Next slide. This is just the geospatial map of Lusaka, where the patients are coming from. PID, we know the Chawama, Kanyama, area, that's John Lane and the like. That's where you have the clustering over there. Pauleni, you can see another cluster there near Nyumbayanga. And another one in the northern side, Kabanana, Matero area, that's feeding into Chipata, and the other one feeding into Matero. So it's the usual areas that we expect. A few, again, in the Charleston area, BIDs there in the southern side, eastern side of the city. These are areas where we need to watch out. And this is probably looking at just the heat map in a similar area. You can see the Kanyama sub-district has got the highest incidence. Next slide. I think this has same information, looking at just superimposing this with the water supply, piped water. You can see that the graphs are speaking that same relationship. This is again toilet problems, washer problems. You can see that going together. As a case management cluster, probably this is not where we want to spend most of our time. Our response is now slowly getting up there, being led by the Vice President and the National Disaster Management Technical Committee, and resources are being availed, including the 27 vehicles, human resource, supplies that we need. We know that we've had a few challenges with beds, which are coming on the fore now as a unit. PS this morning was emphasizing that in areas where you don't have, you can bring in the carpenters and the like to make the beds, but also things like giving sets that we didn't have, now they are coming in as a cluster. We are probably where I would like to be in terms of the response. Next slide. This is on the washer side. clean water is being given the communities, but with those 48 water tanks, but this is for a different cluster. Next slide. So case management, we have 9 CTCs. I think we will be going to Hero Stadium. We are just from there looking at the preliminary logistics. The intention is to have 600 beds there. Across the city, we have those oral rehydration points, but we want to send the message because of the high BIDs that it's very important that individuals come to the centers. As you can see there, we know there have been challenges with space, but those are the measures being put in place probably to move to Hero Stadium, and some of these centers, CTCs, will be decongested. Doctors and nurses are being deployed, and the trainings are being kicked in. We will have them today, tomorrow. Tomorrow we'll spend some time talking about pediatrics, and Friday we'll spend some time looking at special cases, pregnant women, those who come with emergencies, in shock, maybe with cardiac arrest. What do you do? What are the commonest conditions and individuals with complications? For instance, those with comorbidities like heart failure and the like. How do you manage in those special scenarios? Those are the discussions we'll have on Friday. Tomorrow we'll look at the bits. Next slide. So I'll hand over to Dr. Sinkala to take us through just the case management, because he's manning our biggest center of excellence, the Levy CTC. He has the insight with what is actually going on, and he'll be a big resource. Dr. Sinkala, next to you.
Thank you, Dr. Sivile, for that overview. Really a worrying picture on the case management and in terms of the case fatality rates. However, with the interventions that are coming in, we hope that things start to get better. Now, moving on, colleagues, we'll spend the next probably 30 to 45 minutes talking about case management. We shall follow this outline, we'll define what it is. We'll talk about a bit of microbiology and pathogenesis, look at the clinical presentation. Then we'll talk about assessment of fluid status and the treatment of cases. Then we'll look at the discharge criteria. And in the discussion, we'll look at some of the possible differentials. So, IT, are we able to load, have we loaded this 4 questions, or maybe we can just speak to it and then we can hear what people will say. Well, it's not loaded. Oh, okay, it's actually loaded. So, a 43-year-old female presents with an 8-hour history of 8 episodes of profuse watery diarrhea and multiple episodes of vomiting associated with abdominal pain and leg cramps. Skin pinch is more than 3 seconds, as shown in the image to the right. Admission vitals are BP of 87/48 millimeters of mercury with a pulse of 107, which is weak and thready. What is the level of dehydration of this patient? So option A is no dehydration. Option B is moderate dehydration. Option C is severe dehydration. Option D is unable to determine. So we have about more than 150 responses already. We give it a few more seconds for people to answer in the poll, and then we move on. So, Dr. Sivile, these are some of the patients that we are receiving in our cholera treatment centers as shown in the image, where if you look at the skin, it's been pinched, and the skin is still standing 3-4 seconds later. So we have at least 35% have participated. I think we can end the poll here, and then we'll move on from there. Okay, so 82% of the respondents think it's severe dehydration, 3% are unable to determine, with 14% thinking it's moderate dehydration, and 1% saying it's no dehydration. So we'll get to see and speak to this more as we go on in the presentation. All right, so moving on. So, what is the case definition for cholera? So, who is a suspect case in this case? When do you suspect that someone doesn't have cholera? When do you suspect that someone has cholera? Okay. So, in terms of just pardon us a second. So in an area where the outbreak has not been declared, like we saw on the heat map, it's not all the districts which are reporting cases. So in an area where an outbreak has not yet been declared, who should you suspect to be a cholera case? It's any person aged 2 years or older who presents with acute watery diarrhea and severe dehydration or dies from acute watery diarrhea. Now, in an area where an outbreak has been declared, as we saw in the heat map, it's any person, doesn't matter the age, who presents with or dies from acute watery diarrhea. Now, in this case, you're going to ask to say, when we say acute, what are we talking about? So acute, we're talking about duration of 7 days or less. Watery is just that, something that looks like water. Then the diarrhea is the loose stool. Now, for you, in this case, so the diarrhea, will be talking about 3 or more episodes in less than 24 hours. Then that person meets our case definition and should be treated as cholera. Now, getting into the microbiology, a little bit about Vibrio. We know it's waterborne and foodborne. It's a gram-negative aerobic bacterium, quite small in size, 1 to 3 micrometers. Then there are 2 serotypes that are associated with epidemics, O1 and O139, but there are over 200 serotypes. Then in terms of the infectious dose that you need about 10 to the power 3. That is if the gastric acid is neutralized, and these will usually come in with mild diarrhea. The 10 to the power 6, if taken in with food, will usually result in severe diarrhea, and greater than 10 to the power 6, when taken in with water, will usually result into severe diarrhea. Now, you'd ask to say, in terms of the clinical presentation, how are these patients going to be presented? In the preamble, Dr. Sivile did mention to say that only 5% of our patients are the ones that are going to present with severe infection, and these are the ones that we are getting in our facilities. So you will see that the 3,000 cases that we've had, most of those have been the severe cases. 20% will present with mild or moderate infection, with the majority, 75%, having asymptomatic infection. It doesn't mean that they will not be shedding out there. These will still be shedding. However, they will not present with any signs and symptoms. That's why it's important that we practice the correct hygiene and use of proper sanitary facilities because of this 75%. And these are the ones who usually continue to propagate the outbreak. In terms of the clinical presentation, we know it's a dehydrating diarrheal illness with loss of fluid and electrolytes, and symptoms are going to range from asymptomatic infection through mild to severe hypovolemic shock. And the image to your right there is just the typical rice watery stool that we see in our patients when they come to our facilities. Now, before we even get into the other parts, a little bit on the differentials. You will understand, you and me will agree that Vibrio cholerae is not the only one that can present with acute watery diarrhea. There are other pathogens that you will need to keep in mind. So most common is E. coli, it's most common cause of acute watery diarrhea. Norovirus, Campylobacter species, non-typhoid or Salmonella, and the other listed there will also cause acute watery diarrhea. Just to your right, there is just some other examples of what can cause diarrhea, but in this case, it would be bloody, the usual Shigella species, and the enteroinvasive E. coli, and the others that are listed. In terms of the patient presentation, in severe cases, clinical features will include profuse watery diarrhea. They will have multiple episodes, effortless diarrhea. Others will come in with multiple episodes of vomiting. There'll be loss of skin elasticity. They'll have dry mucous membranes. There'll be increased feeling of thirst, increased heart rate. They will present to you with muscle cramps. They'll be restless or irritable. And then there will be all those that will come in, if they come in very late, to come in acute renal failure. BP will be low, when they'll be acidotic. There'll be severe electrolyte imbalances. Those that come in very late will come in coma, severe hypovolemic shock, or unfortunately, there will be those that will come in dead, as we've had quite a number of BIDs that have presented to us. Colleagues, if untreated, 50% of our severe cases will die, but with proper treatment and correct fluid replacement, we can reduce mortality to less than 1%. So that's why we emphasize that our patients need to come to our facilities early so that we keep our mortalities to less than 1%. But if people continue to delay, our mortality rate will continue to increase. Now, fluid loss is what is going to kill our patients. So we need to be on point in terms of assessing our fluid status so that we can correctly treat and try and save our patients. So like we've said, the case definition, anyone who has 3 episodes of diarrhea in 24 hours should be treated as a cholera suspect. In terms of your assessment of dehydration, you are going to examine the condition of the eyes, determine the thirst level and the skin trigger, then check pulse, check the presence of the pulse, check its strength. Is the strong pulse? Can you feel it easily, or is it a thready pulse, or you can't even pick it at all? A rapid thready or absent pulse will indicate hypovolemic shock, and you treat them accordingly. So if you look at this flow chart, the column in green there, if you examine your patient, they are well, they are alert, they don't have sunken eyes, they're drinking normally, the skin pinch is going back quickly, vital signs, BP is normal, pulse is normal. These ones in your assessment, you're going to say these ones are not dehydrated, and your treatment plan is going to be plan A. Now, when you examine them, when you come to in yellow there, they are restless, they're irritable, they have sunken eyes, they have a dry mouth and tongue, they're thirsty, they're drinking eagerly, the skin pinch goes back slowly. When you check their vital signs, the blood pressure will be normal, they have a normal rapid pulse, they would have lost 5 to 10% of their body weight. So these ones, in terms of the assessment, will be moderately dehydrated, and you treat them according to plan B. Now, coming to the part in red, you examine your patient, they're lethargic, they're drowsy, or they're unconscious, they have very sunken eyes, they're not able to drink, the skin pinch is going back very slowly, or it's undergoing what we call tenting. If you check your vitals, they'll be in shock with a low BP, rapid, weak, or undetectable peripheral pulse with minimal or no urine output. They would have lost greater than 10% of their body weight. They'll be severely dehydrated. These ones, we're treating them according to plan C, and these ones can lose more than 1 liter of fluid per hour in the first 24 hours. Now, when we talk about body weight in our setup here, Dr. Seville, if we just do like a random poll, just by a raise of hands, how many people know their actual weight as of today, so that you're able to determine that 12 hours later, I've lost 5 to 10% of my body weight. There are very few. But you understand that with cholera, when you lose 10% of your body weight in the morning, if you're a size 32, by this time you'll be a size 26 by the amount of fluid that you're losing, which translates to your body weight. So you need to keep an eye out for that. Now, in terms of after you have classified your patients as plan A, plan B, and plan C, how do you then proceed with the treatment? And what are the other things that you look out for? So in terms of the no dehydration, those are the things that we're saying. You examine their weight, their alert, vitals are normal, thirst is normal, eyes are not sunken, skin pinch is normal. We're treating them according to plan A. And we'll get into the details of each one of these as we go on. Moderate dehydration, same thing we've been saying, 5 to 10% body weight lost, BP normal, pulse normal, rapid, restless or irritable, sunken eyes, dry mouth, tongue, increased thirst, drinking eagerly, skin pinch is going back slowly. For the children, we'll speak to that tomorrow, so I'll skip on that. Severe dehydration, like we've been talking about, greater than 10% body weight lost. This can lose 1 liter of fluid per hour. This translates 1 liter of water will translate to 1 kg. So meaning you can lose up to 24 kg in a period of 24 hours. That's not a healthy amount of weight to lose. And that's why the mortality rate, if untreated, is very high. So we insist that people come in quickly. Hypovolemic shock, like we mentioned, skin will undergo tenting. When your skin has reached this stage, it's very difficult to pick up the peripheral veins for IV cannulation. Mouth and tongue will be very dry, very sunken eyes. Patients will come in drowsy or unconscious. Now, in terms of the treatment, this is just a repeat of the flow chart that we've spoken to. When we come to rehydration, rehydration therapy can reduce our mortality to less than 1%. Like we said, 99% of our patients can be treated if they come in early. Oral rehydration salts are recommended, and oral rehydration therapy on its own can treat 80 to 90% of our patients. And then those that require IV fluids can be switched to ORS as soon as they're able to tolerate. Now, this oral rehydration therapy, of course, we do have the pre-mixed pack that we're able to quickly dilute and constitute, and the patient is able to drink. Now, in the household setup where people may not necessarily have these sachets, you may encourage them to make the traditional homemade ORS where they get 6 teaspoons leveled of sugar, add to 1 liter of safe water, and then get half a teaspoon of salt, add to the same 1 liter of safe water, mix, and then it should be able to drink, and it does an equally good job. Now, one thing you need to understand about ORS is that the ORS, once constituted, if you do not have a fridge, you can only keep it for 12 hours. Within that 12-hour time frame, you should be able to use it. If you don't use it, discard and constitute a fresh one. Where you have refrigeration services, you can keep it for a period of up to 24 hours, after which you need to discard and then constitute another formulation. In terms of intravenous therapy, Ringer's lactate is the recommended IV fluid of choice. And this is because when the patient is losing fluids, so they're losing their water, there's electrolyte loss, and the electrolytes that they're losing, there's your chloride, there's your bicarbonate, there's your sodium, and then there's the water, of course, that will follow through. So now if you look at that constituent, and then if you compare it to Ringer's lactate has all these constituents. In addition to, there's also loss of potassium, which Ringer's lactate also has. Then Ringer's lactate also has the lactate component, which helps to buffer the acidosis that will go on with the loss of the electrolytes. That's why Ringer's lactate is the recommended IV fluids of choice. And so, colleagues, we need to make sure we stock enough stocks of Ringer's lactate, as it is the fluid of choice. Normal saline or half-strength normal saline, these are less effective because in terms of their constituents, they are predominantly rich in sodium and chloride, and they do not have the other components of the potassium and the bicarbonate or the lactate, which are also being lost and which are very important in our patient resuscitation. The challenge with normal saline is that it will worsen, in some instances, it will worsen the acidosis because it does not buffer the acidosis that is going on in these patients. D5 is ineffective and should not be used in resuscitation because the challenge with the D5 or the 10% dextrose is that because of the dextrose component, when you give it to your patient, the majority of it will be metabolized. The dextrose will be metabolized and taken up into the cells, and then the effective volume of fluid that you'd have given your patient will actually reduce from, say, let's say, for example, you give 1 liter of your 10% dextrose, find that 50% of it will be metabolized and taken out. In effect, what will remain in your intravascular space will only be 500 out of that 1.5, so of your 1 liter. So in effect, you will not be doing a great job in resuscitating your patient, but the Ringers will remain in your intravascular space and it will quickly help in your resuscitating of your patients. So colleagues, Ringer's lactate is a fluid of choice. If we don't have Ringers, let's order in advance where there's no outbreak. Where there's an ongoing outbreak, we make sure we stock enough of these. Now, coming to oral rehydration therapy, we need to replace estimated losses at 100 mils per 5 minutes, replace ongoing losses plus 1 liter daily, reassess your patients every 1 to 2 hours, and patients will need more than 5 liters in a day. Give it, we know by convention, very few people will drink even more than 2 liters in a 24-hour period. But with cholera, your patients will need more than 5 liters. Please, colleagues, let's leave it, let's not hold back. Now, getting back to our treatment plans for various levels of dehydration, when there's no dehydration and you have classified your patient to say they are in plan A, I'll focus on those that are above 10 years. You're going to give them as much as they are wanted, but give them more than 400 mils for each and every loose stool that they have. And here, what we're just trying to do is to maintain hydration and make sure that our patient does not tip into moderate or severe dehydration. Now, let's say your patient comes in and they're already at moderate dehydration or they're at severe dehydration. So we start with moderate dehydration. Here, you need to provide ORS immediately according to the weight and age. And in terms of monitoring, you need to monitor them every hour for the first 2 hours. So our monitoring has to be much more thorough than what we usually do on our everyday rounds. In terms of fluid input, ensure adequate intake of ORS, count the number of cups that they're drinking, measure the amount of ORS that they're drinking. If your patient is vomiting, give them a 10-minute break, and then you administer ORS in nice and small quantities, but ensuring that we hit our target mark. And we'll talk to our target mark in the next slide. In terms of your output, you need to monitor the number and the nature of stools, and then monitor the vomiter so that you're able to monitor the patient as they are with you in real time. You need to reassess hydration status after 4 hours of if you haven't kept your patient on plan B, and treat them accordingly, whether they've tipped into no dehydration or they've tipped into severe dehydration, and you can treat them accordingly. You can administer ORS by nasogastric tube, but only if your patient is conscious. If your patient is unconscious, do not insert the NG tube and give your the ORS, as there's a risk of aspiration as your patient is not able to protect their airway. In terms of how much ORS you're going to give them, you need to be able to determine your patient's weight. And once you have determined your patient weight, you need to multiply it by 75. And that is the amount of ORS that you are going to give them. Where you are unable to determine the weight, you can use the weight bands or the age bands as shown in that table. So for those adults that are above 15 years, you're going to give them between 2,200 to 4,000 mils. That's between 2 liters to 4 liters within the first 4 hours of you being with your patient. So like we were saying, not everyone will drink 4 liters in 4 hours, but with cholera and based on the level of dehydration, you need to make sure that your patient drinks, because if we don't give them that amount of ORS, you tip them into severe dehydration, and then you have challenges to manage them, as we are going to see in the next slides. So in terms of severe dehydration, you need to give your IV fluids rapidly until you take them out of severe dehydration. Make sure your patient has 2 large bore IV lines in situ. For all our cholera patients in the centers, we are striving to make sure that you at least have 2 lines, large bore cannulas that are in. And then remember, colleagues, Ringer's lactate is the best solution of choice. And of course, use a new IV set for each patient that you have. Give ORS only if your patient is conscious. Do not use oral nasogastric route if the patient is unconscious. If they're able to drink, you add for them 5 mils per kg per hour, whilst the IV fluids are running. Now, in terms of the IV fluids that we are giving, like we said, Ringer's lactate is the fluid of choice. How are you going to calculate the IV fluids that you're giving? So here we'll focus on the greater than 1 year or the adults. So there are 2 phases of hydration.
The children, just repeat.
Yes, I'll touch on them as well. I'll start on the adults first. Thank you for that guidance. So for the greater than 1 year, in the first 30 minutes of your rehydration, you want to give them fluids at 30 mils per kg. Then in the next 2.5 hours, you want to give them at 70 mils per kg. Meaning the first phase of rehydration will last you 3 hours, and which you're going to give them at 100 mils per kg. Now, for the first 30 mils per kg, let's take a practical example of someone who is weighing 70 kg, the average adult, meaning 70 kg at 30 mils per kg, you're going to give them 2,100 mils in the first 30 minutes. That's 2.1 liters in 30 minutes of Ringer's lactate. And hence why we're insisting that you need to make sure you have your large bore cannulas so that your 2,100 mils of Ringer's lactate should be able to go in quickly. Then after you have done your first 30 minutes, your next 2.5 hours, you're giving them at 70 mils per kg. Now at this 70 mils per kg for a 70 kg patient, that's going to translate to 4,900 mils of Ringer's lactate in 2.5 hours. And this has to go in as well. Otherwise, you are prolonging your patient stay and your patient stay in the severe dehydration phase. So you notice that in the first 3 hours, you would have given them 2,100 and 4,900, which translates to 7,000 mils of Ringer's lactate, or 7 liters of IV fluids in 3 hours. That's quite a huge quantity of fluids to give, and colleagues, we have to give this amount of Ringer's lactate based on the level of dehydration. Like we mentioned, you can lose more than 24 liters in 24 hours. Hence, even the fluid rehydration has to be aggressive in order to minimize mortalities. For those that are less than 1 year old, for the first 30 mils per kg, we're just doubling the time. From 30 minutes, it now goes on to 60 minutes. Then the one for 2.5 hours, we double it, it goes on to 5 hours, and you give it according to the patient's weight. You'll notice that at the bottom of your screen there, it says 200 mils per kg or more may be needed in the first 24 hours. So for a 70 kg patient, that will translate to 14,000 mils of IV fluids in a period of 24 hours, or 14 liters of IV fluids in a period of 24 hours. And this is not something that we're just saying, these are fluids that we're actually giving our patients. Those that are of higher weight even receive it much more than this. So those that continue to tip back into severe dehydration. Even after being taken out, you will see that they'll get more than the prescribed amount of fluid that we're discussing here. So if your patient, you give them, you assess they're still severely dehydrated, you continue on the treatment of plan C, you will notice that you get 14 liters in a period of 24 hours. And colleagues, it's not unusual in cholera. You go ahead and you give it, you will see that your patient will be safe. In terms of patient monitoring, monitor the pulse and stay with the patient until you have a good pulse. Reassess hydration status at 30 minutes, then every hour until rehydration is complete. Check for a sign of rapid respiratory rate. It may be a sign of possible hydration, and we'll speak to the complications of treatment in a few slides. Add oral solution as soon as possible. Discontinue and remove your given set when your patient is stable and able to drink. Or I said, don't move the IV cannulas. I said, remove the given set, least with the misquoted. In terms of your input, record the liters of IV fluids that you're giving and the cups of ORS that you're administering. Mark each quantity per hour on each bag. Ensure that ORS is within reach so that the patient can easily take. And of course, ORS is easier to take with the patient sitting up. Record the outputs in terms of the nature of stool, and also record for the presence of urine and the amounts of urine that the patient is passing out. So we have discussed in terms of the bit of the microbiology, we've discussed the signs and symptoms, we've discussed a bit of the differentials, how our patients will present, how we assess them, we've categorized them in terms of plan A, plan B, plan C, and we've spoken about how we are treating them according to plan A, plan B, and plan C. So it's not unusual that you have a patient that come in with plan C, you treat them out of plan C, they go into plan B, you put them on plan B, but because of the ongoing losses at your next year assessment, they tip back into plan C, so you recommence plan C, and then you continue just like that until eventually you get your patient out of dehydration and they go on. Now, what are some of the complications that you need to watch out for in these patients? So in the young children, and the elderly, you need to watch out for hypoglycemia, and especially those that come in with severe dehydration, you need to watch out for hypoglycemia, and these will present with lethargy and convulsions. Any ORS and feeding will prevent this and treat with glucose if available. Now, someone will ask to say, but we said no D5 and no D10 earlier on. So now, if you notice, the treatment here is going to be different. We're not going to hang a D5 or a D10 to run. No, you're bolusing your patient with a 50% dextrose, 40 mils or 20 mils has, dependent on your level of hypoglycemia, and then you continue with your Ringer's lactate. Do not substitute the D5 or the D10 for your Ringer's lactate. No, that has to continue. Because once you've taken your patient out of hypoglycemia, once you've taken them out of shock, they are able to drink ORS, you start the ORS early. Remember the ORS, one of the constituents of the ORS is the glucose, so it will sort out the hypoglycemia, and you feed them quite early, it will treat the hypoglycemia. In the elderly and the young children, again, watch out for pulmonary edema. This will be denoted by a new onset cough or rapid breathing while they're on IV fluids. Slow down on the IV fluids, sit your patient up, and this should be able to resolve. If it doesn't resolve, quickly inform the senior on call, and they should be able to guide you on the next course of action. In those that are not receiving ORS, there's a risk of hypokalemia because of the loss of electrolytes, potassium in this case, and this will be denoted by painful muscle cramps. In most cases, the patients will tell you, I can't stretch my legs, or when I stretch, I'm having these cramps. So ORS, Ringer's lactate, should be able to sort this out, and where this is not able to resolve, then you go into the next phase of treating your hypokalemia, and I think that will be spoken to more when we get to the Friday presentation. In terms of other complications, prolonged shock may be denoted with renal failure, and this will be denoted with no urine output, but with the correct hydration, it should be able to resolve, or urine should be able to resume within 6 to 8 hours. There may be a few that may be required dialysis. You need to connect them to the renal team, and then they should be able to take it out. In pregnant women, we have been having quite a number of pregnant women. During this outbreak at Levy, we've had, I think, on average 10 in our CTCs every day. And there's a high risk for miscarriage, especially those that are in the 3rd trimester presenting with severe cholera. There's a high risk for miscarriage and stillbirths. Treatment in terms of IV fluids is still the same pattern that we've discussed, where your patient's Ringer's lactate still remains the fluid of choice. We were joking with our obstetricians to say Ringer's lactate is not contraindicated in pregnancy, and ORS is also not contraindicated in pregnancy, so they can be safely administered. Those that are receiving IV fluids for more than 3 days, you need to monitor for infection at the site of your IV lines. Look out for redness, swelling, and pain. Just may be a sign of infection. Remove that IV line, administer, insert another line on another site, and continue to administer your ORS. So watch out for those complications. In terms of the signs of adequate rehydration, colleagues, you need to, the same things that we're looking for as signs of dehydration, now we need to reverse them to see that your patient has been adequately rehydrated. You look for the skin pinch, is it going back normally when you pinch it? The thirst level has subsided, urine has been passed, the pulse is good and strong. These are signs of adequate rehydration. And I'll speak more to them when we come to talk about in terms of the discharging our patients. Now, colleagues, you will notice that we spent, I think, almost 30 minutes now just talking about rehydration and ORS and drinkers lactate, and we haven't discussed anything to do with antimicrobials. And we've discussed to say 99% of our patients, just by adequate rehydration, we can save them, reducing our mortality to 1%. Just by ORS, we can treat our patients. 90% of our patients can be treated with oral rehydration therapy alone. Now, antimicrobial therapy has been shown to reduce fluid losses. It has been shown to reduce the duration of illness, and it has been shown to reduce the duration of carriage. Antimicrobial therapy is recommended for severe cases, and we know that resistance pattern can change over time. I'll show you a slide of the current resistance pattern in Lusaka. Colleagues, antimicrobial therapy is not recommended for prophylaxis. So we noticed, like especially during COVID, where people were taking azithromycin and giving themselves ceftriaxone and all sorts of antibiotic concoctions, either before entering the COVID centers to go and wait, or when they got COVID and would give our entire households these antibiotics. With cholera, colleagues, it's not recommended for prophylaxis. And so let's not use antibiotics indiscriminately. Let's only reserve them for severe cases. Now, speaking to, in terms of the sensitivity pattern, this is what we have in Lusaka as of December 26th. This was the resistance pattern. So you see tetracyclines was still sensitive. 61 of the samples that we had were still sensitive. 7 of them showed resistance. To Cipro, 65 were still sensitive. Chloramphenicol, 40 were resistant. Cotrimoxazole, 67 were resistance out of 71. That's quite a significant percentage and quite a cause for concern. Ampicillin, 70 of 71. That's almost like 98% were resistant of the samples that we had. So colleagues, let's use antibiotics in an appropriate manner to try and reduce on the incidence of antimicrobial resistance. Based on these charts, which antibiotics are recommended. So for adults who are not pregnant, doxy still remains the recommended one, and it's only a start dose, 300 milligrams. For those who are pregnant, azithromycin, 1 gram in 1 dose. That's the recommended. Then where you don't have this, you can still use azithro for the other adults and Cipro, and erythromycin for pregnant women as the other second choice. In terms of zinc supplementation in children, it has been shown to reduce severity and duration of most childhood diarrheal illnesses, and by approximately 10%. Then in terms of zinc supplementation, 10 to 20 milligrams by mouth per day should be started immediately. You have your children with diarrhea, and it really does help. This year, colleagues, is just an image of one of our cholera treatment centers, not currently in the past, where we have tents pitched up, cholera beds, buckets underneath there, and our officers attending to our patients. So, Dr. Silvile, we would like to have an infectious disease hospital in all our districts or provinces where we can nurse our patients and give dignity, so to say, to the treatment of cholera, because this is one of the factors that is associated with stigma and patients not presenting to our facilities because people don't want to be treated in a tent, and people are saying, no, I don't want to be treated in a tent. That's why I delayed to come. So you see that when people are treated in a better center, they tend to present to our facilities early, and there's less stigma associated with being treated in a tent. And so even colleagues, as we are preparing our CTCs where we don't have outbreaks. These are the factors that we need to be looking at when we prepare our cholera treatment centers. So a bit of summary of our treatment colleagues: no dehydration, ORS, maintain hydration; moderate dehydration, ORS to replace the losses as well as to maintain hydration; severe dehydration, IV fluids, remember Ringer's lactate fluid of choice; switch to ORS when tolerated, antibiotics only for severe cases. Treatment complications, you need to watch out for them, zinc supplementation for all our children. In terms of maintaining hydration therapy, you need to, when you have hydrated your patients with IV fluids or ORS and reassessed and there's no dehydration, there's no signs of dehydration, you need to continue to administer ORS to maintain normal hydration. The aim is to replace stool losses as they occur with an equivalent amount of ORS. And so this is something that you need to even speak to when we discharge our patients. Once the patient is discharged from the cholera treatment center, it doesn't mean that the diarrhea has stopped. No, you still have 1 or 2 episodes when you go home. The key thing is to be able to replace that loss with ORS even when you're at home. Because you notice that when you go home and the diarrhea still continues and you don't replace the ORS, you will tip into moderate then severe dehydration and you come back as a readmission. So when we're discharging our patients, we need to be speaking to that, colleagues. Then the amount of ORS required to maintain hydration is going to vary greatly amongst your patients depending on the volume of the stool that is passed. And it is going to be highest in the first 24 hours of treatment, and especially in large patients, especially large in patients who present with severe dehydration. Like we said, in the first 24 hours, average requirement of ORS will be 200 mils per kg, but in some patients, they may need as much as 350 mils per kg. And we need to be able to give this amount of fluids. Continue to reassess patients for signs of dehydration at least every 4 hours to ensure that enough ORS is being taken. Now, in terms of your discharge, for those that came in with severe dehydration when you admitted them, you need to ensure that, first of all, they've met the three criteria before you discharge them. What are these 3 criteria? Number 1, there needs to be no signs of dehydration. The same things that we talked about, good pulse, vitals are back to normal, skin pinch is okay. Those are the signs that we were talking about. 2, 3 or less liquid stools and no vomiting in the last 4 to 6 hours. The no vomiting is to ensure that they're able to keep down the ORS that they are taking. Then number 3, the patient or the person that is taking care of him, or in the case of the children, has demonstrated that maintenance therapy can be taken at home without supervision. Emphasis, colleagues, on the 3rd point is that the patient should be able to take maintenance therapy at home without supervision, because if they're not able to take the maintenance therapy, they are going to tip back into moderate and severe dehydration, and they will come back as a readmission. So we ensure that they are able to take the ORS, and when we are discharging them or before we discharge them, we cancel them on this part. If they're not able to do that, then you are going to keep them until they're able to do that. For those that came with some dehydration, again, same things, no signs of dehydration, no vomiting, and the patient is able to take care of themselves, or they're able to have someone who is able to supervise. Those that come in with no dehydration, you need to ensure that the patients, once you have kept them and you've observed them for 4 to 6 hours, they're able to drink sufficient amounts of ORS. After each stool, they're not vomiting, and they're easily able to return if their condition deteriorates. So, dear colleagues, we have had, I think, almost 40 minutes of speaking to cholera. I think before we open it up for sessions, I'll hand back to Dr. Sivile just to add on to a few points here. Dr. Sivile?
Thank you, Dr. Anel. He's an infectious disease registrar. He wants an infectious disease hospital. Yeah, so Dr. Anel, when I was like you, I think 2017, when I was a registrar in infectious disease, I was called to see a patient at Hero Stadium. Then we were responding like we are doing right now to the cholera epidemic. Then I was like what you're doing, the one in charge, technical, for the treatment of patients with CTUs. So this patient was termed to have renal dysfunction. It was a lady, I think in her 40s, and had was anuric, wasn't passing urine. So when I reached the center, I asked, how much fluid have you given? They said, doctor, we've given 9 liters of IV fluids, and the bags were there, and the patient was still anuric. So what do we do? I think this has got renal failure. She has renal failure. We need to take for dialysis, one of those things. I looked at the patient, examined the patient. They were surprised that I ordered another bolus of 2 liters in 30 minutes as I was there. And after we gave, the patient passed urine, and we didn't need to take the patient for dialysis. There's usually a lot of fear to give a lot of fluids. So cholera, like you've rightly said, Dr. Nell, it's all about fluids, and you have to give a lot of fluids. Unfortunately, sometimes we have these small bags, the 500 mils, it's unable, and the recording in the center sometimes is not done judiciously. I think those are the things we want to emphasize, colleagues. Within the first 3 hours, you have to give at the very least someone who is in C, you have to give at least 6 liters. That's a lot of fluids. Those who come in shock, within the first 30 minutes, at the very least, you have to give 2 liters of fluids, and actually even faster than that, because your guide is your pulse and the BP getting into normal. So we want to emphasize that the fluids requirements are huge. That's one side. The first assignment you have when the patient, and most of the patient, like we've said, who you will receive will be actually those who have severe dehydration. Otherwise, they will not seek care, of our behavior in health-seeking behavior. So the first thing you need to do is deal with the replacement. He gave the 10% deficit or what. If you do that, multiply that in terms of fluids, that will be 7 to 8 liters. So that is your deficit. When your patient is coming, they are already behind by 7 liters. That's what they're behind with. That's why within the first 6 hours, you need to replace, that is the deficit. But as you will note, when you go in the center, you'll find that these patients, while they're in the center, he showed you the pictures of the beds. They'll have a bucket in beneath. That bucket will be full. Sometimes it's a 10-liter bucket, will be full in 5 hours, in 6 hours. Those are the losses you need to replace. So in addition to the deficit of 6, 7 liters, you need to replace what the patient is losing, which will be huge amounts. Sometimes it will be 12 liters. Like that particular patient that I found, the patient had received quite all right, 9 liters of fluid, but what they had lost in the bucket, there was 11 liters. Already the patient is behind, right in the center, So we cannot overemphasize the issue of replacing the fluids. For adults, you will be unable to even cause pulmonary edema in cholera. Yeah, for children, it's a possibility. For adults, that's not probably what you need to worry about, because the losses are really, really high. We will spend time on Friday. We'll advise people to connect, where we'll look at the acid-base balance, those hypokalemias and so on, the acidosis, because these patients, the commonest presentation is diarrhea. When you look at the pathophysiology, by the time the patient begins to vomit, unlikely that it's because of the ileus and the whatever, it's usually because of the acidosis that has kicked in. So those are the things you need to be quite aware of, or it's because of the ileus. Otherwise, vomiting is a bad sign. It's a sign that the disease has actually progressed. Otherwise, the typical presentation should be diarrhea, and there shouldn't be fever as well. Once you start seeing fever, start thinking of those other differentials. Usually diarrhea, which is not too much, with fever, salmonella becomes the commonest suspect in that case, if you look at his differential. Because right now, again, if we have hygiene problems which are causing cholera, you know that that's also a risk for other diarrheal diseases like salmonella or typhoid. But the distinguishing factor will be the fever, and at that point, the antibiotics becomes critical and also the investigations should be critical. The other point I want to add on to the core is the diagnostics, which he didn't mention. RDTs, very, very useful. Sensitivity over 90%, 91% over there in meta-analysis. Specificity a bit lower, ranges between 80 and 85%. But that's good enough for our diagnostics right now. I'll open up for questions. That's maybe Dr. Ziambo, you can help us. You know the machines better. You are free to put in the chat. I don't know what's there, if you are seeing anything, Dr. Ziambo.
So you monitored the charts so far. There hasn't been any major questions coming.
Okay, so please feel free to raise your hands, and we can have a discussion probably in the next 15 minutes by 16 hours.
So we do have some hands.
Okay.
So the first one, Dr. Chengamo.
Dr. Chengamo, I'm sure the comment is on pediatrics, our favorite pediatrician. Dr. Chengamo, you have the call, you have the floor. Dr. Jonathan? We can't.
Maybe IT can help unmute.
Thank you. Sorry, IT had the option to unmute locked. The issue you mentioned about the bags of fluid of 500 mils. I know I was part of the team that pushed for the 500 mils bags, but that was meant for pediatrics, and it should not be a standard, where you receive 500 mils bags, because to manage an adult with 500 mils bag is a lot of hassle. So it's important, I think, that medical stores or ZAMSA be engaged on that so that adult packs can also come through. Thank you.
Thank you, Dr. Chengamo. I think as clinicians, your concerns are ours in this sentence. Waliko? Waliko, you have the floor. Just written Waliko. We cannot.
Yes, good afternoon.
Good afternoon.
Yes, thank you for the presentation, Doc. We've really learned quite a number of items, but I was just concerned on the environmental aspect of it. When we are in a cholera management center, I would want to know how the management will be. Mind you, there are some people that have been deployed, that have joined the ministry, and there are some districts that actually are recording these cases for the first time. How would they manage issues of infection prevention and the part of contact tracing? So we would request that if we can have another presentation that could actually talk about environmental management, talking of how do they dispose the same excreta when a patient because I'm sure other people might just throw in the toilet, which again comes back to the issues of contaminating the environment and bringing the cycle to zero, because now the environment becomes infectious. So would request that maybe we set up another meeting that will talk about issues of infection prevention. And I'm happy that you've talked about issues of misusing the antibiotics, because I remember there was some guidance within that were just unverified, where they were talking about giving doxycycline to the contacts, but you've guided that there's no need of giving those antibiotics to people because that would be unnecessary. So I request that maybe we can have guidance on how we can be able to go on that other things. I submit.
Thank you, Waliko. We can definitely promise you that the tomorrow session, one part will be IPC, the other part, like we've done here with epidemiology, we'll deal with IPC and also the pediatric component. And we can just emphasize that antibiotic stewardship is needed. Actually, for cholera, if you look at the pathophysiology, it's the toxins that the organism does produce. And antibiotics are probably not the main treatment. The main treatment is fluids. You can successfully treat cholera even without antibiotics. Thank you. Trevor Hamwemba.
Good afternoon, Doc.
Afternoon, Trevor.
Thank you so very much, Doc, for the presentation. It's a clear and well educative presentation. I just want to comment on the availability of fluids in the centers. I think there's need for ZAMSA to provide these fluids, seeing that this cholera is spreading at a faster rate. Then the other issue is on the community sensitization on the same issue of cholera. We know that cholera is more in Lusaka, but people are moving. People move, they'll go to Lusaka, they'll carry it to another place. So there's need to sensitize these other places where cholera hasn't been recorded yet. Mr. Wadiko has mentioned on the issue of IPC, not just in facilities, even in homes. People need to know how to handle these excreta when they have a case in the home. So the issue of community sensitization, I don't know how it can be done, maybe radio programs, so that it can be done on a massive thing. So my main point was on the issue of community sensitization and IPC and the issue of fluids being available in centers. I submit.
Yeah, thank you, Emmanuel, on that. Yeah, so as a response team, if somebody says we can't see the RCCE, the community sensitization and engagement, it means it's not there. Yeah, but I can tell you that efforts are being made to even increase, means it's not reaching the community. The fact that you brought it up, actually this morning when we were in the IMS meeting, the PS told us that the minister herself wants to get on that vehicle with the megaphones to go through the community herself to speak. I'm sure she's going to do that, but just to say that the IMS, it is a priority, and we are going to push that more is done. Yeah, fluids, organizing ourselves in terms of commodities is an ongoing process. They haven't been, from the case management cluster, that hasn't been the biggest of challenge, though we need to improve to make sure that these are available. In our previous responses, yes, we did reach some point. I remember in the big one of 2017 that we started running out. We haven't reached there. The challenges that we've had were mostly in the giving set, of which frantic effort is being done to make sure that that is corrected. And I'm sure those in the centers, they can attest that the situation has actually improved. But definitely, it's time that we need to prepare and make sure that we all have adequate stocks for these commodities, even in those facilities and areas where we haven't recorded a case yet. Sesheke CDC team. Sesheke, you have the floor. It's just written Sesheke. Okay, Muno, Dr. Muno,
Good afternoon.
afternoon.
Sure. Thanks, Doc, for the good presentation. My question is on availability of RDT testing kits vis-a-vis the cholera outbreak that we have. Are they available in all provincial headquarters or probably at the ministry? Can they be accessed, at least even in districts that have not recorded any case, so that in case we have any suspect, we are able to test locally? I submit.
Yeah, so Sesheke, they are available countrywide. Actually, Western Province, you do have them. I think we had a report in the morning from Dr. Lavde Mwira, who's here, that you used some in some of your patients that you had. So you can just connect yourself to Dr. Lavde Mwira and the team at the province. They should be able to guide for what you need. Obviously, the stocks are not endless. That's why our emphasis is really that we are using a case definition. You actually don't need the test to say this person goes into a cholera center. The definition is somebody with a case definition of diarrhea. That's 3 loose stools in 24 hours is considered as a case of cholera right now. So even in the centers that we have in Lusaka, even previously in the previous epidemics, not everybody who's in the center had a positive diagnostic test. That is not required. Even in areas in this country which haven't recorded a case, because we are an endemic region. So you might be in Kafue district or Mazabuka or wherever. You do not need that particular diagnostic test to say this person goes to cholera. Obviously, it's required. The test needs to be required for epidemiological reasons, but not for clinical management. Not for clinical management as a cluster. As a cluster, we are using that test definition and it's treated as such. I hope that is very, very clear. It's usually a source of controversy, a source of confusion. People, I know as clinicians, we always want to have that diagnosis, we confirmed it and so on. It's always nice, but it's not a requirement. It's not a requirement, and nobody should chase anybody from the CTC to say you don't have a diagnosis. Of course, we do encourage that clinical acumen should be made. For instance, if somebody has those stools which are not so profuse, it's an HIV patient with a low CD4 count, that's probably chronic, and the histories, you get it, it's chronic diarrhea, it's a diarrhea which has been there for over 10 days, 12 days, 15 days, that's probably not clinically cholera because it's not acute. The incubation period for cholera, it's actually 48 hours. So it's an acute disease. You know, you will have exposure within 48 hours to 72 hours with a lot of diarrhea. That's what the case is. When you have a case, you will not miss it. You know, clinically, the diagnostics are for epidemiological reasons, not for clinical management or for admission in CTC. Emmanuel or Mono, we had asked for Mono, probably that, and Emmanuel will be the last person who ask, since we are continuing tomorrow. Mono.
Wonderful presentation, Doc. My question is with regards to what measures have been implemented to ensure that the current situation, or rather the current situation to cholera, is being managed as a holistic approach in terms of collaborating with other stakeholders, such as, of course, the Ministry of Health. We are looking at the water and sanitation. the local government, the business community, of course, our community leaders, the church and the schools. Let us remember that very soon, next week, schools will be open, and it poses a threat to our school-going children, and which will come down to family effects as well as a nation at large. And the other aspect is what other health promotion activities have been implemented, and at what level of digital literacy is being done with regards to cholera? I submit.
Thank you, Madam Mono, for that question. So the lead, like I've said, is gone high all the way from the vice president, and that should tell you that it's multi-sectoral. DMMU is on top of it. All ministries, relevant ministries you mentioned, are actually on the floor and doing their piece. So typically when we have outbreaks, we do have what is called an IMS, which is an incident management system. This has got clusters, units that do different things. Usually there are about 12 clusters. So there are those who deal with messaging, those who deal with water, environment, and so on. So this cluster is for those of us who are dealing with treatment once you have cases. So more or less we are at the tail end of the issue. There are bigger players where most of the actions, like the water, we've shown some of the things that they are doing, where they're putting Ministry of Lusaka Water and Sewerage, working with Ministry of Green Economy, and also local government are putting water tanks, which they're giving people water. National services is involved. So it's a bigger component, which probably I'm not the right person to speak to. Our part is the treatment cost. So those are things are being done. The other multi-sectoral responses. But like I've said with the other comment, if the public cannot see it, it simply means that more needs to be done, and the relevant individuals are actually working over the clock to make sure that those are done. As a cluster, obviously, we do participate in the whole response meetings, and we are aware of what they're doing. For instance, during this long holiday, almost every day we are meeting with, being called by the DMMU to look at what's happening. Yeah, and obviously in the ministry, there are different units as well, looking at different things, led by the minister and the PS to do. For our part, for this meeting, is just the case management. And we're actually the tail end and the smallest component of cholera response. Yeah. The last person who asked was Emmanuel, right? Yes. Emmanuel? Emmanuel, you have the floor. All right, we can ask Innocent Schone.
Thank you very much, Doc, for the presentation. I think it has been precise, and we've learned quite a lot of things. I just wanted to comment on the proactivity in terms of districts around the country. I wanted to find out how proactive are the districts. Are there designated places that has been put, and also staffs on standby in case the situation gets tense? And those teams also, are they going around trying to sensitize? You talked about the minister going around with the megaphone. In other districts apart from Lusaka, because I heard you talk about expanding the center using Hero Stadium, which with about 600 bed capacity, something like that. I want to find out if other districts in the country are also proactive in that case, because people are moving from one place to another, and if we're not careful, I think this can get out of hand. Thank you, I submit.
Thank you for the question. Yeah, so we do have meetings, like I've mentioned, for the IMS. Even this morning, we had one where pretty much all provinces were presenting, including those that don't have cases. And from the case management side, we know that they are ready, they've stocked up, and they have designated areas where, in the event that they would have cases, those patients are individuals who have somewhere to be taken. So these are, it's part of the normal, what we call epidemic preparedness, processes that we do. Places like Mchinga, they've designated the province into the southern and the northern part, with Pika heading as a place, and the other side will be under Chinsari. So there are all those situations preparations that have been put in place. From case management, we strongly believe that we have places to take the patients, and the commodities are also being stored up where they will be needed. But we made a bit more emphasis on Lusaka because that's the epicenter right now. And we hope that the situation remains calm in other areas. For instance, the Western Province, where they've had scares, they tested those people who were negative and so on, let them go. All the provinces are ready.
Yeah, but before we get to maybe more from Mr. Mampamba is here with us. He wants to add on the aspect of logistics. Was the discussion of ringers, lactate, and other commodities.
So we have a logistician, pharmacist.
Thank you so much, Dr. Sibile and Dr. Sinkala. So in terms of logistics, by the way, that's a very important question that was asked, and the response is excellent in terms of readiness and preparedness. So we have submissions being made. I know, especially for those provinces that have not had any case, please, let's not relax. If it means it's stocking up, it's just a matter of time. We know people are still very mobile. So please, just in case where you are, you don't have anything in relation to the supplies that have been highlighted that we use for management of cholera, please do not hesitate to get in touch with the provincial pharmacists. So those are the ones through whom the lists are being shared with the central team to try and mobilize. Of course, we've got distribution lists being made, but we'll always be guided with what you have on the ground and what you really need. So please get in touch with the provincial pharmacists so that those things can be submitted centrally as we try to also stock up from this end. I submit. And maybe just while I'm on the floor, I know Dr. Sinkala talked about issues of resistance, sensitivity, and antibiotic use. I think that one, we really need to re-emphasize that, otherwise it will be the COVID issue where we were creating a bomb out of the pandemic. So we really need to follow those patterns that were mentioned. I know, for example, cotrimoxazole, almost every corner you hear this one say, no, but we have this one, so we may not need other antibiotics. Maybe, Dr. Sinkala, you need to go back to that slide so that people can actually see the patterns that are being shared there. I'm worried for my cotrimoxazole for the HIV program, because it's like people are really going to that. There it is. We know is that orange? The other color, sorry for in terms of some of us may be colorblind, but we can see that resistance is just something else. Yeah, let's share. Okay, IT.
Yeah, that's it. I think we're okay. So
just you can stop sharing. Oh, anyway, it was showing. It's just that screen there. Yeah. Otherwise, it was showing, so we can actually see how bad the situation is with cotrimoxazole. So it's not a drug that we should easily run to. Come again? Yes, it's right. Same with ampicillin. So there we are. About 67%.
67 out of 71.
Yes, 67 out of 71. And then ampicillin, sorry, it's quite small. 70, there we are. So this slide is a serious guide for us, even as we think of prescribing antibiotics where possible, I submit.
Yeah, thank you, Mr. Kampamba. So just to extrapolate that, if you see ampicillin like that, aminopenicillins are the ones that work better for gram negatives. So it means that all penicillins are gone, ordinary penicillins. Yeah, so we still assemble tomorrow at 14:30. We know we can continue discussing, but we wanted to just be here for an hour and a half. So please, tomorrow we'll look at the IPC part, the arrangement of the CTU and pediatrics. And Friday as well, where we'll look at the complications now, acid-base balance, shock. We'll go a little bit deeper into the electrolyte imbalance, why, and some fluid volumes and those kind of things, especially for those who will be responding to the center, to the response, managing very critical patients. So I'm here with Dr. Ziambo, pediatrician. Any comments, Dr. Ziambo? Dr. Ziambo was the district health director at Lusaka during the 2018 epidemic. He was on my neck. He was my boss. Then sending me to all the cholera centers. He has a vast experience. Any comments?
So for me, I think it's just as many first responders who need to have the capacity and training. Let's put people that understand and quickly assess patients enough as first responders. Then we are going to close that gate where we are losing lives. So if we can quickly respond, give them enough supplies and monitor our patients, we are going to close that up in terms of the deaths that may result if we miss out. So tomorrow we'll have a session on children, and then I will emphasize on what we can do in terms of nutrition and monitoring of children. Yeah, thank you so much for your participation. We appreciate. Thank you.
Thank you very much. See you tomorrow and enjoy the rest of the day. Please keep safe as well. It would be a catastrophe if one of us gets cholera who are in the response. Yeah, so we have a responsibility to spread the news to where we are found, our churches, wherever we are, our families, that everybody remains safe. So till tomorrow, I still remind you to be safe. Thank you very much. Bye.
Thank you and bye.
Bye. Thank you.
Thank you.
Thank you.